Okay, well, good afternoon, good evening, good morning, whoever you are, wherever you are. This is Dr. Patrick Lockwood coming back to you again, not live, to kind of keep working along in my six-part series on family, addiction, and recovery. Now, so far in this journey, I've spoken about what the definitions are related to substance use and substance use disorders, and I've tried to explain my goals in the first episode as well. And in the second episode, I discussed the etiology of addiction, the who, what, where, when, and why, as in why people tend to struggle with substance use disorders and the various biological, psychological, and social reasons why people tend to struggle. And in the third episode, I tried to explain the concept of boundaries and why they're important, and then I tossed in a little discussion of triangles and how triangles often play a role in families of people struggling with addiction. In the fourth episode, the most recent episode, I took a stab at Sharon Wegscheider Cruz's family roles, as these are kind of not quite perfectly empirically supported, but generally useful conceptions for understanding how we kind of prototypically interact in family systems with a loved one who's struggling with addiction. And there's lots of caveats in that video about, well, it could apply to all mental health issues, it could apply to a number of different conditions, systemic issues of all different kinds, but generally speaking, they show up pretty reliably in systems with substance use disorders. Today, I want to talk about how to handle relapse, and I want to start off with a conversation about codependency first, and then some basic pointers or principles for handling relapse, because again, you ask pretty much any addictions professional, anyone who is, let's say, certified by the American Society of Addiction Medicine, or who's board certified in their particular state, etc., or nationally, it's going to be the case that we know that relapse is common. It's the norm. It is the rule, not the exception. So treating it as a norm is probably more wise than treating it as an exception. No one wants to relapse. No one wants their family members to relapse. It's just a norm. It is hard to stay sober. Most people, most physicians I'm aware of who are kind of studying this particular issue, this illness, describe addiction as a chronic relapsing disease or chronic relapsing syndrome. So it's not just a me thing. It's not just a California thing where I live. This is what the literature says. This is the general conception, is that relapse is the norm. We wish it were not, but it is. So that's why I want to take this video and talk about all the important variables related to codependency and relapse so that we can have the best chance of handling a relapse effectively, so that we help the person who's struggling with addiction get back on the right path, whatever that path is for them, whether it's a harm reduction path, an abstinence path, some version of a modified use path. I mean, there are many different trajectories for people who want to kind of overcome their illness and manage it more effectively. And I'm not going to sit here and try and pretend like I can say what path is best for each particular person that you might, know. But generally speaking, there are kind of different paths, and one of the big variables that gets in the way of helping the person back onto the path that's going to help them manage their disease, their illness, their mental illness, if you want to call it that, is codependency. And you probably have heard this term in movies and shows, Dr. Drew or Dr. Phil, or, rehab shows or documentaries or whatever. And, this is a word that's tossed around by professionals, by people in the AA world. It's tossed around in common parlance. It's kind of said everywhere. And in today's chat, I want to clear up some misconceptions and explain what the concept of codependency really is or is meant to be, and how it applies and how it can get in the way, and then how we can manage it so that we can help effectively move through a relapse with our loved one better. So what really is codependency? Well, it's been discussed kind of since the AA world was around, but it really came to the fore in the clinical psychology, addiction medicine world roughly around the 1970s. And this was the term that was come up with, or excuse me, that was created to help conceptualize people who are in relationships with people who are addicts. So people who are struggling with addiction tend to have relationships with people of a very specific kind. And although this is a word that most of us have heard, most of us think is probably a real thing, there's a lot of debate about this. So please keep in mind that there are a few very important criticisms of the concept of codependency. Let's talk about them first before I go into what it actually is. So there are issues in the literature, the scientific literature, the psychological science literature, about the concept of codependency since basically the 80s that I can recall. Issues such as conceptual clarity, right? So in the research world, in the science world, the goal is to have your terms clearly defined. And if you have thousands of papers on a concept like codependency, but everyone's using a slightly different term or a slightly varied understanding of the concept, then you actually don't have a lot of solid science supporting it, because you have a bunch of different people using different definitions, which can mean that we're actually looking at different things, especially if one of those different viewpoints on codependency is actually a different concept in and of itself. So keep in mind that there is a reasonable criticism that there are different definitions of codependency that serve somewhat slightly different purposes in the kind of research conceptual sense. Because again, in the 12-step world, when they talk about codependency, it might not necessarily mean the same thing as someone like myself who teaches about this, who studies this, who reads this, who's a psychologist, who's trained it differently. So it's just important to keep in mind that people use this word to mean different things, and I'm going to be using it to mean something very specific going forward in this. A second critique, and this should be kind of obvious once you listen further on in this podcast, that, often this term, codependency, is applied to women in relationships of men who are alcoholics, and that's kind of been the standard AA model since the 1930s, etc. Is it's the wives or the husbands who are codependent on the husbands. So there's a kind of a feminist critique of this concept, which I'm not going to get too much into, other than to say that yes, obviously there might be a bias, a gender bias, but as I'll point out later, there's actually research that shows that there's not as much bias as one might think, and it actually shows up differently depending upon the circumstance. A third critique of the concept of codependency is, well, isn't it normal for people to change their behavior when they see their loved one get sick and struggle with a mental illness or a physical illness? And the obvious response is, well, of course. Of course it's normal. Why wouldn't it be normal? So there's a critique of codependency as kind of a pathologizing view of human nature and how people react to a normal, obvious stressor. So those are kind of the three biggest critiques. So for me, the conceptual issue is well taken. It's a point well taken, and I'll keep that in mind as we talk here. The gender issue is less so, because there's plenty of research that shows that males struggle with codependency and the traits of codependency. Males can struggle with concepts like being overly worried and have low self-differentiation no differently than females can. So it's all about the sample and the sampling structure, etc. And finally, the pathologizing critique is, again, I think it's important because on the one hand, we need to have descriptive words to help people understand and make sense of their experience. So for many of you, if you're listening to this, codependent might be a decent label for your behavior in this role as a family member of a loved one with an addiction. So I want to say that again. If you are a family member of a person who struggles with addiction, then it might be fair to describe your behavior or your role as codependent, back to the kind of the Wegscheider-Kruzes roles. They're just roles. It's not meant to pathologize you. It's not to say that your whole person is codependent. It's just that maybe this is a decent way of describing your behavior as kind of like a model or a schema or a prototype of how people in this circumstance tend to function. And there's research that I'll post in the caption that you can read and you can scrutinize and see if my breaking it down makes sense or not, as always. So, what exactly is codependency? So I want to provide you two different kind of definitions. First, let's talk about a pattern-based definition. And then a second definition is basically a symptom definition. So let's start with the pattern definition and then move on to the symptom definition. So the pattern definition of codependency is it's a dysfunctional pattern of interacting and problem solving that is A, nurtured by a set of rules within the family system, B, rigidly adhered to regardless of interpersonal consequences, C, it maintains a problematic behavior such as drug use, and D, it allows for denial to remain among family members. So the four parts of the, let's say, pattern definition of codependency is it's a behavior. It's a set of behaviors that are driven by an internal rule set within both the system and the individual that are rigidly adhered to regardless of consequences, that maintains a problematic behavior such as drug use, that also allows for the entire system to remain in denial about the problem behaviors such as drug use. So I hope that's clear to everyone. Now let's talk about the kind of symptom definition, like you might find like a DSM or something. So common symptoms of people who we would call codependent or people struggling with codependency include things like fear of expressing your concerns about the person's drug use, your loved one's drug use. Fear of setting boundaries, which we already talked about in the third episode. Rigid attitudes about drug use. You can only use, you can only not use, etc., etc. Feeling unrealistically responsible for the patient or the loved one's feelings or outcomes. Like, if I say this, they're going to relapse, as an example. Difficulty making decisions. Do I say this? Do I not say this? Do I set this boundary? Do I not set this boundary? Do I give them $10 for gas? Do I not give them $10 for gas? What do I do? Another criteria is denial about the severity of drug use. And this is, again, back to the magician stereotype for the addict. This is just part of a systems dynamic where you have to be in denial in order for their magic tricks to keep working. And then another common sign or symptom of codependency is secret keeping. If I see this most often in family systems where a young adult or a teenager is struggling with addiction, wherein maybe the young person has relapsed or wants to use or is talking to an old friend who uses or has re-engaged in an unhealthy relationship with a romantic partner who's struggling, etc. And one of the parents or one of the siblings is going to keep it a secret so that the rest of the system doesn't find out, because if they find out, maybe the system will intervene on the person struggling with addiction. Right, so secret keeping. Another common symptom is external locus of control, feeling as if all of your decisions are purely based upon the other person, the addict's behavior. Kind of a minimizing of your feelings and your needs is a common sign of codependency, where because your loved one is struggling all of a sudden, and emphasis on the phrase all of the sudden, you feel as if, there's no space for you to deal with your frustrations, your fears, your concerns, your anger, your sadness, your confusion. Another symptom is excessive rationalizing, where you're kind of going through mental gymnastics to make sense of things. Another symptom is avoiding confrontation. Maybe you start to notice problem behaviors in the person who's struggling with addiction. Maybe you notice that they are exhibiting pre-relapse behavior where they're going to fewer AA meetings, or they're not going to therapy as much, or they're not exercising as much as they used to be on a consistent basis, or they're, re-engaging with old using friends or whatever it is, and you don't feel safe, you don't feel comfortable confronting them. Another symptom you can look out for is just a consistent pattern of mismanaging your relational dynamics where there seems to always be conflict and it doesn't ever seem to stop. And then a final symptom, which might not seem so obvious, especially if you're a parent and you're listening to this, but there's this concept of parentification. Again, not perfectly scientifically valid, but it definitely shows up where parents, because of their struggles, normal or abnormal, sometimes young children kind of get lost in the wash and they end up becoming like young adults. Your 12-year-old becomes a very responsible 12-year-old and almost like a parent. And then as you see this dynamic develop as a parent, you start to kind of rely on them like adults, when in reality, that's not at all how they should be relied upon. So sometimes parentification is a sign of codependency because, again, naturally speaking, if, let's say, in this prototype, you're a parent and you're struggling with codependency, you're going to feel overwhelmed, exhausted, confused, and unsure about what to do. And sometimes if you really do believe wholeheartedly, sincerely, that this 15-year-old or 12-year-old child of yours is actually competent, and they might be particularly competent and kind of sophisticated and thoughtful and insightful and conscientious, then you might reasonably want to rely on them, even though generally speaking I wouldn't recommend that because they need their own space to be their own self and develop at the age of 12 or 15 or whatever. So you kind of use them, you kind of rely on them as a crutch to make your adult decisions. And I know that sounds kind of harsh, but it happens. And if you don't believe me, just walk into any CODA meeting, Al-Anon meeting, AA meeting, treatment center. It's there. It happens. So these are the symptoms. This is the symptom perspective of codependency. I hope this makes sense to everyone. So I've given you like a pattern definition, and I've given you a symptom definition. So just as an FYI for everyone, codependency is a concept that is measured. It's measured, it's studied, it's researched. It's not super popular. It's not the thing that's going to show up in the New York Times in a newspaper or whatever, but it is measured. And there are different measures that kind of hint at different concepts, constructs. But I'll just name a few of them so you just have an idea of what exists. So the first one is the Codependency Assessment Inventory by Friel in 1985. And then you have the Acquaintance Description Form, C3, which is by Wright and Wright in 1991. Then you have the Beck Codependence Assessment Scale by Beck in 1991. And you have a Codependence Test by Kitchens in 1991. And then you have the Codependent Relationships Questionnaire by Kritzberg, in 1985. The Recovery Potential Survey by Whitfield in 1991. Then you have the Spann-Fischer Assessment by Spann, Fisher, and Crawford in 1991. And then the Potter-Ephron Codependency Assessment by Potter and Ephron in 1989. And then finally the Holyoke Codependency Index, the HCI, by Deer and Roberts. And to the best of my understanding, I could be wrong about this, but to the best of my understanding, the Holyoke Codependency Index and the Spann-Fischer seem to be the most well-researched that I could find. But there are newer ones that have been created. Again, notice that most of these scales were created between 1985 and 2000, so they're kind of older in the research world. So just be aware of that. But again, some of these have a lot of good data behind them, some don't. The HCI seems to, the Holyoke Codependency Index. So this is kind of the broad picture. It's a concept that we research. It's a concept that shows up in the real life. There are symptoms, there are patterns. So how does this show up? Does this just magically develop the moment your loved one starts struggling with addiction? And then what's the mechanism that causes codependency to show up with? Like how? Why? Well, I would encourage you to read widely about this before you make any decisions about how you came to be in this space if you're struggling with codependency. I would say there are so many books to read, and if you want to check out some of the references, please do. One of my favorite books is by a previous mentor of mine, so I'll own that relationship up front, by John Daly. And it's all about adolescent addiction and attachment, and it talks about the interpersonal neurobiology underpinnings of addiction for young adults and adolescents. And I think that's a decent read for anyone who has a young adult or a teen struggling with addiction, and it helps you understand your role a little bit. So from my point of view, how does codependency come to be? Well, I think of it this way. I think there are three variables that drive codependency. So the first one is our our attachment system, if you want to call it that. So our attachment system is our innate drives, kind of hardwired drives to be close and be in relationship with people. Kind of John Bowlby's attachment theory. So our attachment system is, it's common across all mammals. We all have this desire to be close and be connected because it's what helps us survive effectively as a species. So we all have an attachment system. We all have a need to be in close relationships. And there are obviously very different reasons why people are more or less warm and fuzzy, who have a desire to be more or less close. Maybe you have attachment issues. Maybe you're more introverted. Maybe you're more extroverted. There's thousands of reasons why your attachment system might show up differently in different circumstances. But overall, we all have a core, primal, fundamental need to be close and be in relationships with each other. So I'm just going to call that our attachment system. It's a variety of behavioral and thought-based mechanisms for making sure we stay in relationship with each other so that we survive and thrive, etc. So that's the first variable that drives why we struggle with codependency. The second variable that drives why we struggle with codependency is our fear system. So I know that if academics listen to this at some point, I know that generally speaking, there's a lot of debate in the affective neuroscience world about there being actually a fear system, or whether it's not a variety of systems, or if it's a variety of pathways in the brain. But for the purposes of this talk, so it's simpler, I'm talking about the main pathways that authors like Jaak Panksepp have pointed out that show that if you activate these pathways in most mammals, there is a basic kind of fear-driven response emotionally, affectively, and then behaviorally whenever there's a threat in front of us, right? So we have an attachment system that's designed to keep us in close relationships. We have a fear system that's designed to basically help us identify and manage threats. And we have two types of threats that we experience as mammals. We have threats to our physical survival, and we have threats to our relationships, because again, back to the attachment system, we need people. In fact, it's a fair statement to say that many of Jaak Panksepp's fear system neural pathways overlap with a lot of what we would call our attachment system pathways in the brain. So between our attachment system, which is responsible for making sure we're in close relationships and we feel connected and we feel as if we're on the same page with other people, which includes concepts like empathy, theory of mind, reciprocity, and then our fear system is kind of part of that, plays with that, which is responsible for keeping us safe, keeping us in a state of low arousal, keeping us in a state of out of threat, etc. And then the third variable is kind of a catch-all, and this would be everything from your family of origin issues. So were you neglected as a kid? Were you abused as a kid? Did you struggle with mental illness as an individual? What norms around parenting did you learn? What norms around being a romantic partner did you learn? What norms around being a sibling did you learn? All that stuff. So kind of your family history, your social modeling, your learned behavior. And that kind of stuff. So your temperament, your learned behavior. So between these three variables, your attachment system, your fear system, and then all of your unique circumstances and what you learned and how your environment shaped you, between these three systems, these three variables, we develop what will be called codependency. And the reason is very straightforward. Most of you who have a loved one struggling with addiction are either parents or romantic partners or siblings of some sort. In all three of those cases, the person that's struggling with addiction is crucial for your life, for your well-being. And you might even be at a place where you cannot stand the person because of how dysfunctional their behavior is or how poorly they've treated you, which is all reasonable. But the truth of the matter is your kind of hardwired Darwinian instinctual process is, I need my tribe. I need the people in my family. I need closeness. I need to feel safe. So if you have these primitive needs that say, I need you even though you are unsafe, even though you are unstable because of your addiction, even though, you might die, all these things, what happens is, over time, when the magician's act starts to wear off, when the person struggling with addiction starts to show their hand, when the consequences of their behavior become out of their control, because most of the time people continue using drugs, etc., until it gets out of control and they can no longer manage the consequences, whether it's because they overdose or because they owe too much money or they get kicked out of their apartment. Something will eventually happen where they will have crossed a line where they can no longer manage the consequences. And that's when the magician's act starts to become perfectly clear to you as a family member or a loved one. At that point, when you start to see them struggle, is the moment your attachment system and your fear system and all that you learned as a kid, etc., shows up and it starts to be on hyper alert. Oh crap, this person's in trouble. But everything was okay. So now you have an extremely strong fear reaction, an overreaction of your fear system, etc. So when your fear system and your attachment system are kind of overactivated, so to speak, what happens is you start to panic and become worried. And you start to become hypervigilant, so to speak, almost like someone who's been traumatized. Not saying it's comparable, just saying it's a similar process in some ways. So this feeling of hypervigilance and fear leads to being on the lookout for, is my loved one struggling? Are they relapsing? Are they using? And then usually what happens is your loved one can become stable again. Maybe they get sober. Maybe they stop drinking. Maybe they go to AA for a minute. Maybe they get a DUI. Maybe something happens and everything's good. But unfortunately, relapse happens, and then your fear system and your attachment system and all your childhood stuff gets activated again, and then you freak out. And it happens again. And because it happens in a non-predictable way, right? So with the exception of you growing up in a household with someone who struggles with addiction, most people have this very, let's say, unpredictable experience with their loved one who struggles with addiction. They can't predict the relapse. They can't predict the next thing that happens when they first start to notice that the person's struggling. So as they're learning the magician's act, their fear system constantly gets hijacked. And because it gets hijacked in a very, let's say, random way, our brain learns that this is extremely important, essentially. So beyond its normal biological evolutionary importance that, oh my goodness, my loved one's going to die, right? It goes another level up because now you've activated kind of the variable interval, variable ratio reinforcement schedule, which is the most reinforcing schedule that we have in behaviorism. So essentially, there's this normal level of, oh crap, things are bad, but now that the person's relapsing and consistently struggling, and they're struggling randomly in unpredictable ways when you're first learning about their addiction and their magician's act, etc., that your brain learns that it's extremely important because that's how our brain takes in information. It takes in variable interval or variable ratio schedule information as, oh wow, this is significant. So what happens is your fear system and your attachment system essentially become hypersensitive, or you could call it hypervigilant, and now you become like trauma survivors where You're on the lookout all the time. You're reading into things all the time. The person may not even be doing something deceptive, etc., but you might be reading into it because now you've been so sensitized by what has happened that everything has to be read into so that you can predict the next bad thing that's going to happen, the next relapse, the next bad relationship that your loved one's going to have, etc., etc. So that's the etiology of codependency. It's a fear learning process, essentially. Our attachment system, our fear system, and our childhood learning, etc. stuff all mixed into a stew of fear. I call it like a fear stew, essentially, to the point where we become hypersensitive and we overanalyze and think about things because we are trained, because that's how the variable interval, variable ratio schedule works, right? It's the most kind of addictive or rewarding thing. That's why some people call codependency like an addiction itself, but it's not. But it's just, it follows that same behavioral principle of interval ratio, or variable ratio, variable interval schedules. So it's just our brain takes in the information as, oh crap, this is very important. So we become on guard. We develop a new homeostasis, right, as being in a state of fear, being in a state of constantly worrying about our attachment figure, etc. So that's the etiology of codependency. It's a fear learning process. We learn to be in a fearful state with regard to our relationships. And you might be asking yourself, well, does everyone who has a boyfriend or a girlfriend or husband or wife or partner or friend or sibling with addiction develop codependency? No, of course not. Plenty of people are doing their best to have healthy boundaries with the person struggling with addiction. And it'd be fair to say that the ones who do struggle might struggle for a variety of reasons. One of the leading theories about why certain people struggle with codependency whereas others don't is that, and it's by two authors, Knudsen and Terrell, and their theory is something like that many who struggle with codependency could kind of have this hypersensitivity already, or a predisposition to this hypersensitivity, this fear attachment hypersensitivity, because they grew up in a high conflict family themselves. Right? That's the third variable. Now again, this is not me blaming families, because again, everyone's kind of doing their best. It's a hard world that we live in. You know, things are better than it's ever been, but it's still a hard world, and everyone does their best. So I'm not trying to blame parents. It's just that this theory shows that maybe it's because they grew up in high conflict circumstances themselves. Another theory is that maybe they grew up in families with addiction or substance misuse problems themselves, etc. So there's a variety of theories as to why people might be more prone to developing a codependent role. And the best one I found is that basically if you grow up in a high conflict family, your fear system is already sensitized and your attachment system is already sensitized. So it's kind of preferentially responding to the outside world, looking for things to be fearful of. Another thing that we generally know about people we would describe as codependent is that what we would describe as less well-differentiated people are more codependent. So what does that mean? So people who are less well-differentiated, so this means that people who have not, let's say, separated enough as they're part of a group identity throughout development. So throughout development, something that's supposed to happen across many cultures, if not most cultures, it's not all, but across many cultures, what most teens, young adults are supposed to be doing is they're supposed to be developing a more coherent, more strong, more individual sense of self, and then placing that sense of self in relation to the family. So there's a me versus you, an I, thou, right, that exists. And what the research shows is that people who have a less clearly defined sense of self as an individual, but they still have a clear group self, so to speak, are more often to be codependent. And what's interesting from the research I found, and I'll share all this in the caption with you all, is that, believe it or not, across very different kinds of cultures, codependency doesn't seem to differ too much, especially when using standardized scales that were even created here in the United States. So I found research from Taiwan, from Greece, from Iran and Bulgaria. Very different cultures, essentially. And they all kind of show very similar results, distributions of scores, etc. on measures of codependency. And also as an FYI, I found a number of articles in Indian and Russian journals, but because I have no sense of the journal quality, I didn't really dig too much into them, but there were a number of them. So it's not as if this concept is not studied, and it's not as if this is not a cross-cultural concept. Now, again, we don't know how solid a concept it is, but so far it seems like it has at least very good face validity and pretty good content validity for most of the measures, etc. And one of the other things that the research shows is that the kind of relationship you have with the person struggling with addiction might impact their potential for relapse, which is, again, why most people we would describe as codependent struggle with that, let's say, false positive problem. They've kind of falsely predicting that something bad is going to happen because they've seen very high cost, high consequence, bad things happen in the past. That's that fear sensitization thing I was talking about earlier. So there's good historical precedent if you're someone described as codependent for your fearful, hypervigilant way of being. Now, does that mean that you need to always be that way? How do you get out of that? How do you manage that? It's a good question. I don't know. We'll talk about it later. Also, what I found interesting in the research world that might be of importance to you is that there are themes that show up among people who describe themselves as codependent. So there's a lot of phenomenological research that, not a lot, that's not fair, excuse me. There are a few phenomenological studies that I found that describe codependency, or people who describe themselves as codependent, with three different themes. So the first theme that shows up for most people who describe themselves as codependent is a lack of a clear sense of self. Another theme is an enduring pattern of extreme emotional, relational, and occupational imbalance. So their life just seems kind of chaotic and out of whack. And the third theme from the phenomenological studies was people who describe themselves as codependent often kind of blamed their current problems on their childhood and their parents not being appropriately involved or even abandoning them. So from the empirical side of kind of randomized trials and empirical research, and then from the qualitative research side, you can see that there's a little bit of overlap, that people who describe themselves as codependent do struggle with having a clear sense of self, that do struggle with a strong sense of internal chaos that spreads out into their real life. They do struggle with this history, this self-reported history of high conflict family, abandonment family, etc. And themes like being out of control. So there's a fear issue in both the empirical and the qualitative literature world. And just as a quick aside, we actually have a few studies, not many, that look at the brain and codependency, and one that kind of correlated personality traits, which I thought was interesting, and it found that, that it was a very small sample, but in this small sample of wives of male alcoholics, they found that high scores on measures of neuroticism correlates with high scores on measures of codependency. So the question is, which one's really driving the boat there? Is the neuroticism causing the codependency? Is the neuroticism setting you up for codependency? Is the codependency causing the neuroticism change? Hard to say. In terms of the neuroscience stuff, I found one interesting, but again, small study, small sample study, which is important because small sample means not very generalizable, and questions about kind of data. But the study showed that for people who self-described as codependent, there was a hyperactivation of this area called the dorsomedial prefrontal cortex when they actually looked at pictures of their loved one who was addicted. So just looking at pictures hyperactivated the dorsomedial prefrontal cortex. Why is this important? Because this is the area of the brain that's implicated in a variety of things like empathy, fear management, fear processing, theory of mind, and mentalizing. So basically, this could indicate that, especially if this study is replicated over and over and over again across cultures and ages and genders and all that stuff, that, the hypersensitivity is obvious in brains in such a way that it's reliable, which means that we can kind of target it effectively with behavioral and cognitive choices, which leads us to, well, how do you manage codependency and how do you manage relapse? So let's shift just a little bit. So I looked pretty long at PubMed and Google Scholar and different search databases for interventions for codependency, and most of the studies were very low quality, too small a sample, very undetailed in their interventions, etc. But I found a decent review by Abadi and colleagues, and this was in 2015, and they listed a few interventions. And most of these interventions that I'm about to list, I basically use in my clinical practice and recommend as well. So the first intervention that should be kind of a no-duh at this point is family therapy. And I would say family therapy ASAP if you have a loved one struggling with addiction. It is worth your time, your energy, and your money to have a solid family therapist. Whether that's a therapist at a rehab or an IOP or a private practice family therapist, it doesn't matter the location. If they're quality, that's what matters. And the reason's very simple. The family therapist is specifically trained in different systems theories, interventions, different areas of the research, etc., that allows them to understand dynamics that your classic individual therapist does not have training in. I was trained as a classic individual therapist. I currently teach a number of family therapists for California Lutheran University, and the truth of the matter is, it's a different world. What I was trained in as a clinical psychologist versus what they're trained in as family therapists. And I've now kind of fortunately and unfortunately become very well acquainted with the family therapy literature as a result of teaching. And the truth of the matter is, they're taught very different things that most of my colleagues only have one class in. They have a whole 3 or 2 year master's degree in, essentially. So what I would say is that a solid family therapist is going to see things that you're not going to see. They're going to have wisdom and training that will help you manage your system, manage your behavior, your boundaries, etc. very effectively in a way that you can't quite see. That's my main reason for doing so. Another strong recommendation from the Abadi article is family support groups, which are hosted by professionals like myself or by, treatment centers, etc. And, you might have to try a couple to find ones that are quality, where they talk about the research or evidence-based practice or, effective coping skills, things like that. A third recommendation from the Abadi article is assertiveness training and coping skills training. And this is basically what would be called cognitive therapy for most people, or behavioral therapy. So the truth of the matter is, most people who struggle with those symptoms or that pattern of behavior I described in the definitions are not very assertive. They tend to be very fearful, avoidant, etc., and for good reason, obviously. And they tend to not be coping with their fear states very effectively or often. So if you can go to some individual therapy, get some assertiveness training, get some coping skills training, heck, just go to YouTube and find a diaphragmatic breathing video. I think there's one from Michigan or somewhere like that I always recommend to people. Just do something to manage your fear better. It'll help. And finally, the Abadi article recommended kind of standard 12-step support groups like CODA, Codependence Anonymous, Adult Children of Alcoholics, and Al-Anon. And again, there's no good empirical data on those 3 groups, but they seem to be helpful depending upon your culture, etc. So how do you manage relapse then? Which is kind of the main goal of this chat, right? So, first and foremost, if your loved one relapses, the first thing you need to do is acknowledge that the relapse is not your fault. Your loved one made a choice. Even though you're part of a system and your behavior does have an impact on them, you can be a source of stress. Just because all that's true, that never means that you are responsible for their behavior. And I hope that's abundantly clear that yes, on the one hand, we are humans, we're flawed, we're simple, we're primitive, we do impact each other. It is almost without fail that when we do something, say something to each other, that we cause a response in both ourself and the other person. The type of response, how strong that person responds, the intensity, the frequency, the meaning of that response is on them. And then what also is on your loved one is what they do with that response, whether they choose to cope or not. Basically, anything short of physically forcing your loved one to use drugs is not your fault. So I hope that's perfectly clear. And the reason I say this and I start with this is because the vast majority of the time when I work in family therapy or I do educational groups, people blame themselves for relapses when that couldn't be further from the truth. You do not cause a relapse. You might contribute to the stress that the person uses to justify their relapse, which is fine. That's normal. That's healthy. That's being a human being. We make sense of our environment. We take stock of our stressors and we cause and we blame and all that stuff. It's not sick. It's just how we work. But you cannot blame yourself for their behavior. That's nonsense. It's ludicrous. You do not need to feel guilty. All you need to do is understand that you might be a source of stress and you need to do your best to manage the behavior that might be stressful. That's it. Nothing anxiety-inducing, nothing dramatic. The second thing, I want you to always ask yourself, what is the difference between supportive behavior and enabling behavior? Because the truth of the matter is, it might not be perfectly clear to you. In fact, even as a clinician, sometimes it's unclear to me. Even though I'm slightly more objective in many cases, it's still the case that I have emotions, I get tricked, I like patients more than others, etc., and I might enable. So the question you need to ask yourself in a non-anxious way is, what is the difference between a supportive behavior and what we would call an enabling or codependent behavior? And I listed the symptoms up there. And one decent point of clarification here is the general goal is for the person who relapses to take responsibility for their drug use behavior and the consequences caused by their drug use behavior or the behaviors they do to get their drugs or stay high, etc. So if they rob a place, that's on them, not you. All that stuff. So more broadly, I'd say we can have the category of like rescuing behavior, where we kind of try and help minimize the consequences of someone's drug use or consequences of their consequences on one end of the spectrum. And on the other end of the spectrum, there's kind of supportive or assisting behavior. Now, another thing to watch out for is sometimes we get angry. Sometimes we're very fearful or hurt that someone has relapsed. And we might want to even punish the person ourselves for relapsing. You have to avoid that urge at all costs, because there's a difference between setting boundaries and realistic consequences for realistic behavior versus punishing someone excessively because you're hurt or fearful. So our general goal is to live in between the two extremes of rescuing, which is enabling everything, giving them lots of money, making sure they never feel bad about a relapse, making sure that all of their stressors are managed by you and not them, essentially. So that's rescuing on the one side. And then on the other side there's generally what we would call supportive behavior, which is, I'll give you a crystal clear example. So-and-so relapses. You have the question of, okay, what do I do? Do I help them find treatment? What do I do? Do I take them to a doctor? Do I take them to the ER? What do I do? Well, the first question is, what do they need? And they might know that, right? Another question is, have you asked a professional what they might need in that circumstance? A third question is, what's the least risky behavior on your end that makes you the least fearful in that moment? Another question you might want to ask yourself is, if you're supporting someone, does that mean you're doing the work for them, or does that mean that you're simply guiding? I tend to think of supporting as more like guiding and less like doing. Are you the one on the phone with the treatment center, or can your loved one who struggles with addiction be on the phone with a professional? Now, there might be the case that they're going through horrific withdrawal and they might not be okay with talking right now because they need to go vomit. That seems understandable. But generally speaking, I would say that if the person's relapsed and they're in a clear enough headspace and they're not, struggling with acute withdrawal, etc., then there's a good chance that they may be able to do some things themselves to help clear up the wreckage of what they just did. Maybe it's, calling their therapist or calling their sponsor, or whatever it is. Why would you do that for them? Etc. And generally speaking, much of our caring behavior is driven by fear. Even in non-addiction contexts, fear is probably the biggest driver of a lot of what we do. So you need to be aware of that. So generally speaking, supporting is guiding and nurturing, whereas rescuing is forcing, making, doing, etc. And you can notice this even in the way you talk. Well, I did my best to keep them sober. No, you didn't. That's not your job. You don't keep anyone from being sober. I don't do that. As a psychologist, I don't do that. All I do is support people in their journey. I don't force or keep or maintain or manage anyone. Finally, another metric that I use with family members is kind of a fear scale, continuing on from the last topic. So typically, our moderate to severe fear about our loved one's well-being, about using, or potentially using or relapsing, is an indicator of how problematic our reaction will be in terms of how our behavior shows up. So because the fear tends to cloud our judgment, with the obvious exception of your loved one being in a literally life-threatening circumstance, what can they actually handle right now? If they want to relapse, is it your job to keep them from relapsing? No. Is it your job to be supportive of them? Yes. What can they really handle? If they want to use drugs, can you point them to resources? Do you get on the phone for them? No, not generally. But what can they handle? The problem is if we're too fearful, then we might either misread the circumstance or we could overreact or underreact, both of which it could be due to fear. So my first recommendation there about fear is just working on yourself, your self-care, coping skills, managing your fear, diaphragmatic breathing, mindfulness meditation, yoga, exercise, getting good sleep, etc., etc. The healthier you are, the better you'll be able to read the circumstance, generally speaking, and be able to manage your emotional state so that you can be more present for them and help guide and encourage them and not let your fear drive you to do things that we would classically call enabling. And last but not least, please just seek out professional assistance. There is no need to handle these situations on your own. Because it's a totally reasonable problem to be human. We're human. We have a bias. We have history. We have feelings that skew and tint and change how we see our loved ones who are struggling with addiction. That's normal. That's not sick. What's abnormal or what's problematic is if that becomes an impairment in everyone's ability to grow and succeed and thrive. Not that you have to be perfect, just that if you notice a pattern of behavior on your part that you consistently do with your loved one struggling with addiction and they're still struggling to use, maybe there's something that you can self-reflect on there. Or better yet, maybe you can go see a professional who, hopefully, dear God, has less bias than you and can see the dynamics and the risks more objectively than you, because that's what their job is. Otherwise, we wouldn't have them and we wouldn't need them. So please seek out help as needed, because it is not your job to fix anyone, because people are not watches. They're not clocks. And it is not your job to manage other people, your kids, your young adult kids, your siblings, your partners, your family, etc. It is not your job to manage them. It is your job to support and encourage and nurture. And that looks very different depending upon what stage of change they're in and what level of dysfunction they have, if there's comorbid depression or anxiety or multiple substances. There's all sorts of variables that make it very hard to see this problem clearly. And that makes it very hard to see our behavior in response to the problem clearly. And the best person to look at that and do the 13 levels of analysis is a professional. So please see a professional. And if you need help finding someone in your area, let me know. For free, with no reservation, I will happily help you. Okay? So, thank you for listening. Please like, share, subscribe. Please send this video to as many people as you can think of, because my goal is to get a reasonable take on codependency out there that's non-pathologizing, that just allows us to examine our behavior simplistically so that we can kind of be more effective in our relationships. Any feedback is welcome. Please, please share. Please, please. Okay? I hope you're doing well in the quarantine. I hope your mental health is going well. If you need anything, please find me at my website, patricklockwoodhealing.com, or on Twitter at psychplockwood, and I'll do my best to be supportive. Okay? Have a good day, and I will talk to you soon.